right, there we go. So we are back to recording now, but I want to get started. First of all, I want to thank Justin Withrow for joining us today. As you guys know, throughout, I'll say Facebook land, there's always a million questions about different legal topics. And I personally prefer to get my legal advice from an actual person who kind of, studied the law. And, I know for me, Justin. Um, for those of you who don't know, and I'm going to let Justin give a quick intro before we get into it here, but, I actually had Justin come speak at one of our events in Atlantic City. Gosh, that was like 2 years ago now.
It's hard to believe, actually, that it's been that long.
It is. I don't know where the $900 went that I won playing blackjack that night, but
I think that's gone too.
it's gone. It's definitely gone. Um, but had Justin come speak, it was actually a great conversation. We always do like a Q&A session at the end, and I think you kind of overran the Q&A section. Every single question was for you. But I want to talk today because there's been a lot of questions. It really started out as being a discussion about the utilization reviews that every dental office, it seems, has gotten from Anthem in the past month or two. Um, Started out to be that, and then, you know, very hopped on to some other topics, but I want to get through them and give people a chance to kind of ask any questions that they might have. Um, so, with that being said, I want to introduce Justin. And Justin, if you want to give, the 90-second elevator pitch on
Yeah.
what you do and who you are, other than me saying, I ask a lawyer, let's ask Justin, because you're just the lawyer. So, you know, tell everybody what you do.
Sure. So, Justin Withrow, I'm a partner at the law firm Flannery George Alice. I practice predominantly out of our firm's Cleveland, Ohio office, but regularly find myself visiting our firm's other offices that are located in Pittsburgh, Detroit, Morgantown, West Virginia, Charlotte, North Carolina, and then we have another Ohio-based office in Columbus. Unfortunately, I've been blessed that my practice sort of takes me all over the country, even into states where we don't have a physical presence. And so I lead our firm's dental practice group, where I have the privilege of representing providers and practice owners of either solo practitioners all the way up to multi-state, multi-location organizations in a variety of different regulatory enforcement matters. What I spend the largest portion of my time is in insurance audit defense, and either assisting right from the moment where a request letter is received, or perhaps one of those utilization or education letters, all the way through appealing any findings of the auditors themselves. Represent providers and practices in board investigations, and then also when they happen, and it's unfortunate that they do happen, state and federal criminal investigations. So predominantly what I spend my time on, but outside of the regulatory enforcement, do a lot of just business advising and complex business disputes, again, predominantly for those dental industry professionals.
Awesome. So you're in the know on a lot of the stuff we're gonna touch on and be talking about today. On a totally unrelated side note, did you ever hear from that other one over the weekend?
I did. Yes, I spoke. I spoke to that person over the weekend on Saturday evening. And I'll just say, oftentimes when I have, and I consider it an honor for folks like yourself to refer their clients to me when they have an issue where I may be of some assistance. I really do consider it, an emergent circumstance. Even if after having that conversation, it may not be as big of an emergency as anyone may feel. The greatest fear is the unknown. And so needing answers to questions and just wanting some comfort, is hopefully something that I can provide. So I very much consider it a 24/7 responsibility, and there's no off days, even on Veterans Day.
Right. Right. Exactly. That's the way it works. I mean, listen, I get it, and for me personally, and I'm sure for a lot of people, having that fear of the unknown,
Yeah.
I mean, I listen, I get audited by the IRS every single year. Every year for the past 21, I get audited. It's just a recurring thing. My travel expenses are high because of the seminars and traveling for speaking events and whatnot, and I get audited every year. And I still 21 times have opened that envelope and gone, "Oh my God, oh crap." And I call my lawyer and he's like, "I know, I got it 2 days ago. You knew it was coming." Like, calm down, just having that calming, the sky is not falling presence out there, I think is worth the cost of whatever it is that you charge.
Yeah,
So,
well, and that's right. And so, for a conversation like that, I don't charge people because, look, I don't, people are coming to me for help. And so, if it's to ask a few questions and, make some decisions as to whether, an attorney-client relationship on the go forward is something that they think would be beneficial to them, well, then, of course, yes, that there's going to be charges related to that. But to just get some additional background information, get a better understanding as to what process looks like. Um, I may be a bad business person, but I just don't like to charge for those conversations, and don't plan to start now.
yeah, no, that's a good thing. So, I'm gonna share um the there we go. The utilization review, and hopefully everybody can see it. Can you see it there?
I can.
Okay. So this was because this is where we'll get started. This is an actual utilization review chart that came in from Anthem Blue Cross. And this one specifically came to I will say, brand new client that we just brought on weeks before they got this letter. And, when we bring on a new client, we kind of go through the process of looking at their billing history and looking at the things they're sending out. And I had already had conversations with this doctor about like the number of buildups. Like, there's no way 89% of the crowns you're doing require a buildup. There's no way 88% of the extractions you do are surgical. And we had already
Yeah.
had those kind of discussions. But then this letter came in and they kind of freaked out a little. And well, understandably, but over the course of about a 2 week period, we had about 15 posts in the group of people posting their letter, their utilization review from Anthem Blue Cross. And everybody got really freaked out about them. And I'm like, listen, they're not. And I kept wanting to share this one and say, yours isn't bad. Like yours is one a three surface filling. It's one code, and they're saying you do 17% where the average dentist does 14%. Like this isn't a big deal. Look at this one. But I couldn't just keep sharing the same thing over and over again. So, can you kind of walk people through or help people understand like what this is and why insurance companies do this and I guess what it could potentially mean for them in the future? Because everybody thinks this is like This is step number 4 on the way to a 5-step audit.
Yeah, so I like to consider these, and I've always called them educational letters, and it's the insurance company's way of educating the provider, the practice owner regarding statistics and data that the insurance company has evaluated and comparing the practice or the provider to other similarly situated providers in the area. And as it says in that large lettering at the bottom, based on the size and age composition of your practice's patient population, they're comparing you, and here it's a number of different procedures in comparison to other similar practices in your area. And when they see that there's a large statistical gap between you and other practices in the area, you're on the radar, if you will. And so, what does it mean to be on the radar? Well, it means that it's likely that you're going to receive one of these letters where there's bar graphs and charts and comparison statistics where they're putting you on notice that we think that you are not properly utilizing certain codes and you need to take note of it. Now, I love what you said about this particular client that received this letter and freaked out. Now, we never want a client to freak out, but when a practice receives this letter and is quickly nervous and uncomfortable, those are the clients that I like to have, because it means that they're well intentioned, and what we really could be talking about are deficiencies in training and education. Whereas a practice that receives one of these education letters, looks at it, scoffs at it, crumples it up and throws it in the trash can, those are clients that are unquestionably going to be more challenging to work with, because they're not taking the warning signs that the insurance company is providing you seriously. Because I am of the opinion that when a practice receives one of these letters, they're being put on notice that an audit is forthcoming. And that now, between the date of the education letter and whenever the insurance company ultimately makes that decision to commence an audit, is an opportunity. It's an opportunity for improvement. It's an opportunity for self-evaluation, either internally through your own internal protocols, or perhaps utilizing external resources, professionals like Rick and his team, my team, other professionals that do this sort of insurance related work, to make sure that you are utilizing the codes correctly, that your documentation practices are up to standard, so that if and when you are selected for an audit, you've either made all the necessary corrective action that will be favorable in the eyes of the insurance company, or you've tightened up those record keeping and documentation practices so that when selected for an audit, you don't feel that heightened sense of nervousness, that concern, because you've already done the necessary legwork on the front end to ensure that your record keeping and documentation protocols are going to withstand scrutiny.
Right. And I think that is where I think, and you've been through 100 times more audits than I have. But I think that's where most dentists fail, is the documentation.
Oh, sure.
It's such a huge thing. And the I'm gonna pop that off the screen there now. But the office that how do I stop share? There we go. The office that got this letter specifically, the one that was just up on the screen, looking at the documentation for every one of those surgical extractions that said forceps and elevator used, tooth removed with no complication. That's not a surgical extraction. Surgical extraction requires either sectioning of the tooth or
Yep.
the removal of bone. And if you're saying I used an elevator and forceps and the tooth popped right out, that's not a surgical extraction. Or people think, well, sir, I'm coding it as a surgical because it took extra time. The patient was complicated to deal with, and it took 30 minutes instead of the normal 6 minutes it takes me to extract a tooth. It's a surgical because I should be compensated for my time. Your
Well, in
document,
surgical extractions versus simple extractions, that is such a heavily scrutinized code and procedure by insurance companies. That's one of, those codes and procedures that they're so frequently looking to at audits because they know that, the surgical extraction should not be used nearly as prevalently as the simple extraction. And so when they have data that suggests that they're close or even surgical extractions exceed simple extractions, that's an easy indicator that there's likely misuse improperly of the surgical extraction code.
right? What are some, I mean that's actually brought up a good question then. What are so like the surgical versus simple? What are procedures that are those red flags for insurance companies?
It's a good question. I feel like it's an ever-changing list, but crown and build-up procedures are always going to be a popular one. I see root canals being scrutinized pretty frequently, and not necessarily from did you perform a root canal? Yes, that's generally easy to identify, but rather, they will make an assessment as to whether the root canal performed rises to the standard of care. And that's an entirely separate assessment beyond just was the procedure documented and the procedure that you billed for the procedure that was actually completed based on the documentation. Multi-surface restorations are another one. The surgical extraction, those tend to be the ones that I see most frequently. There are also denture codes that are in there with some prevalency, and those are oftentimes tied to those surgical extraction codes. But if I had my team on here, I'm sure they would be kicking me and telling me, you're not thinking of X, Y, and Z. But those are the ones that particularly stand out to me.
Okay. What about did you say scaling and root planing?
Oh, I'm sorry. Of course. Yep. SRP. Absolutely. Of course. Of course. That one is very prevalent. And almost I'm trying to think of, the audits that I'm working on currently, and I'm pretty sure they all involve SRP.
Yeah, because that's a big one.
Yeah.
And I think it's because people get the order out of whack or they're overdiagnosing or maybe they're not. Um,
Well, and in my opinion, that is a procedure where documentation practices, this is an unfair characterization across the board, but where I see there are really below par documentation practices where they're not doing the documentation that necessitates justifying the SRP, or they're doing, multiple quadrants of SRP in one visit that, oftentimes faces scrutiny from insurance companies as well. But it's really the documentation of the SRP that repeatedly we are confronted with in our defense of providers that can be problematic.
and just real quick, not to side rail anything, but somebody already asked in the Q&A if the recording will be available. And just so everybody knows, the recording will be available. It will be available publicly. I'm going to send out the link. I'm going to post it on our YouTube channel later on today, and we'll send out the link to it to all the registered attendees. I'll also post it on my Facebook and in the group. That way, everybody can see it, can get out there. I mean, that's why we do these webinars at no cost and make them publicly available, because I know both Justin and I are huge believers in educating I won't say public because we're not dealing with muggles, but educating the dental community about these things because we deal with them all the time. I get 5, 10 phone calls a week from offices being audited. You probably get way more than that. And it's just I'm being audited, and I hear so often it doesn't happen. They're not really out there auditing offices.
Okay.
They are, yeah. But so yes, the recording will be available. It'll be on our YouTube channel. It'll be all over Facebook and everywhere. And actually, I called this webinar interview with an attorney part two because we did our part one 2.5 years ago, right before the Atlantic City trip. And it's like my second or third most watched video on the channel, which is awesome. I think the only one that beat it is the one where I was bitching about my dentist that was ripping me off, uh, trying to charge me for a perio maintenance because I got an extra cleaning I got an extra prophy every year. And he's like, that's a perio maintenance if it's an in between. That That's the only one that beat it, and that's just because people like drama. Everybody loves to hear the
Yeah.
tea, so that's what it is.
I
But
will say just a short divergence here. The group, the Facebook group, is such a wealth of information. I constantly find myself, learning from both you and the other, posters or frequent commenters and other contributors to the group. I've never worked in a dental office. I don't have the experience that 95% of the participants in your group have. And so I continuously am amazed by just the wealth of knowledge that, folks have. And for the most part, how people are willing to provide gentle guidance and advice. I know it's not always the case, but, by and large, people are always willing to provide commentary and guidance to those posts from folks that are new or learning or trying to figure out a complicated issue. Because I think, we're all confronted with very similar issues in the practices or the professions that we work in. And so to have a resource like your group it is truly awesome. And I think I'm sure everybody that's listening is a member of it, but if they're not, they absolutely should be.
I appreciate that. Thank you. And yes, it should be nice now because the hammer is dropping on the keyboard trolls. Um, so we're trying to get them out of there. But so now another question that just popped up, we could answer that one quick while we're on this topic. Just curious what percentage of crowns require, it says coats, but I think we're going to go with buildups. Um, because that's what we were talking about here. So, what percentage of crowns do require that? And I mean, I don't know your opinion. I think it's a clinical choice. You
Yeah.
just have to have the documentation that backs it up.
Well,
Why?
exactly right. And so I have this conversation pretty frequently. It could be 100% in some practices. It could be 1% in other practices. It really just depends on that particular patient that's in the chair at that point in time, whether it's a necessity or not. And so you can't really put a percentage on it because every patient is different and every patient may or may not need it. Um, and so going back to the statistical outlier aspect of it, some practices will just be a statistical outlier, either because they, cater towards a certain demographic of the population, or they've become the trusted resource for a particular type of procedure. These things happen. I mean, someone is always going to be a statistical anomaly compared to other similarly situated folks. That's fine, provided that your record keeping and documentation practices again, will withstand scrutiny, and that you're properly utilizing the codes, you're billing and coding things appropriately. If all of that is happening, then you get an education letter and you shouldn't feel nervous. Or if you get a request for 30 to 50 patient records, you should feel confident that, while it's unlikely that you will come out from an audit not having to repay any money, the objective is to keep the dollar amount as low as possible. And again, it really is training and education. So often I see that, providers just have a fundamental misunderstanding as to what the documentation expectations and requirements are. And, when they don't know what they don't know, they can't possibly know how to comply with the rules and regulations of their, state Medicaid program or the provider agreements that they're a participant in. In fact, I was just talking to a new practice owner who received an education letter, and we were talking about their documentation practices. And I said, well, tell me about how you document procedures. I mean, do you use the traditional SOAP note format? And they had no idea what SOAP note meant. And admittedly, I was a bit taken back because I thought that that was still how practitioners were trained in school to document encounters. And we eventually got there. I mean, they talked about all the necessary components of a traditional SOAP note. They just hadn't heard it referenced in that manner. And again, I think there is a real gap in really understanding and education that takes associate dentist into practice owner. And it's a big step that you make. And I think, when someone decides to make that step, they have to make sure that they have, the guidance and expertise around them to ensure that, like this provider is currently going through, they're not receiving a education letter 6 months into their doors being open, because that's a clear red flag that something is wrong.
Yeah. Yeah, that is a big one. And I did want to touch on that, but I have a feeling that's going to be a little bit longer of a conversation than the next 30 seconds. But you said something about root canals being high on the list of red flags right this minute. And I wanted to just share, I just popped the screen share up there. This is an EOB that came in the past few months. And it's the insurance company denying a crown because, I mean, we all know that you have to send a PA x-ray for the crown for the claim to be processed. And they're denying this, not making the crown or the buildup the patient responsibility. It is a 100% write-off to the practice. And the reason is there's a poorly filled root canal visible on the PA that you sent to get the crown paid. And, I put this EOB up a month or two ago in a class I was teaching up on the screen, and everybody went, "Oh my gosh, I've never seen anything like that before." And I'm thinking, really? Because I see it every single week. How how are you not ever seeing this before? And this is the problem, I will say, with root canals, is the documentation requirements or the processing guidelines for the insurance companies say they want to see those x-rays, and then you underfill or overfill a root canal, and you wonder why they're saying we're not paying for that. We're not paying for you to do a bad job.
Yeah.
And I don't understand how people don't get that, I guess. Maybe I need you to kind of talk me down from that cliff, because you just sent an x-ray that shows you did a bad job. It's medicine. It happens. Nothing is perfect. That happens. Surgeons are taught to deal with people dying on the table because it happens. It's part of your training. You're gonna have a poorly filled root canal. be glad
Or
to.
you're going to have an open margin on a crown. That's another thing that we see with frequency when you're submitting X-rays in support or as part of an audit defense. The X-rays may show certain open margins, and they will seek recoupment for the crown procedure because of the open margins, or as you said, underfill on a crown. Yeah, or root canal. Excuse me. Yeah, we see that all the time. We see that all the time.
Yeah.
And they can be particularly challenging to overcome because at that stage the insurance company has gotten typically it's the dental director involved in that level of review. They cannot rely on just certified coding professionals to make those sort of clinical determinations. And so those poor prognosis and clinical decisions are made by a licensed dental professional.
Right. Exactly. And that, Devon is in the audience, Devon Banks.
Hi,
And
Devon.
one of the things that she typed in was also poor perio prognosis. We see that
Yep,
one all the time.
it's another good one.
The tooth has a poor, she says hi. I don't know if you can see the Q&A, but um, poor perio prognosis. The tooth has 8 millimeter pocket depths and you know, 3 millimeters of bone loss, and you're doing a crown, or you're using it as an abutment for a bridge. What is the long-term prognosis? Furcation involvement, bone levels don't support it, no opposing teeth. We see that one all the time as well.
Yeah.
There's so many things, and I think, and I don't know if maybe I take it too personally, but I think there's so many dentists out there that try to do like Hail Mary dentistry, and it just doesn't work. And I say this all the time. Dental insurance doesn't pay for Hail Marys, or they're
Yeah.
not supposed to. Sometimes they do, and then they go, oops, we're catching this 9 months later. Give us our money back. And you're going, but why? What? Because we don't pay for Hail Marys. And I hear so many people say, well, I'm just trying to help the patient. They can't afford a crown. So we're trying to save it with a 17 surface filling. We're just trying to help them out. What can I say to those dentists that are like, I'm going to do what I can. Insurance has to pay it because it's a covered benefit.
Yeah, I mean those are situations that we're typically confronted with when we're involved in a Medicaid insurance type audit where it's a common retort, and I totally recognize that you get a Medicaid insured patient in the chair. Generally speaking, there's going to be a need for a lot of dental work to be performed. And there's no certainty that that person, in all likelihood, it's unlikely that that person's going to come back for their 6 month check-in appointment. And so I hear regularly, I'm going to do all the work that I can, that this patient needs, while they're still in the chair. And, I think that they're well intentioned, unquestionably, but that doesn't mean that the insurance company is going to support that philosophy, support that practice, and pay for all of that work that was performed. As you said, they may do so initially, but upon further review, certainly those procedures may not withstand scrutiny. And unfortunately, it's also where I find the documentation to be particularly lacking as to why all those procedures were done, or what the diagnosis was. That's where that information tends to be lacking the most.
Yeah. And I don't want to get into all this right now, but I will just say I also see so many facilities, I won't say practices, but facilities that do the per interaction. They get paid per interaction. And then it's we're going to have you come today for a occlusal filling on number 3 and tomorrow for a distal filling and the next day for a this, and they really split it up, and they think nobody's going to catch on to that either. And that's incredibly problematic. But now there's another question in here about documentation, courses specifically. But one of the things I wanted us to talk about, and this was the thing I thought might take longer than a minute, is documentation requirements. Because I had actually posted a screenshot of the letter that I forwarded you last week, um, the Delta review, and one of the things that was on there that I was kind of flabbergasted that people didn't realize was the 36-hour clinical note rule. And people were like, well, there's no rule. Does my state have a rule about like documentation requirements? Does the dental board have a rule about how long I have to do clinical notes? Can you kind of touch on that? Is there requirements? Because everybody said, well, that's a Delta requirement. I don't have to do that if I'm out of network. I don't have to have my notes done in 36 or 48 hours.
Yeah, I mean, I will say that, there are a variety of different rules. I think that a good rule of thumb, I mean, I always say within 24 hours, but, frankly, no later than 72 hours. And anything beyond that, and quite frankly, that even makes me a bit uncomfortable. There is a breakdown in protocol. And if you can't get your documentation for patients that you've treated that day completed within the next 24 to 48 hours, then you need to revisit, how our documentation practices within the practice itself. There's simply no reason why, a patient record should go 3, 4, 5, 6, 7 longer than that days where the patient encounter is not documented and then ultimately signed by the doctor. That's another thing, Rick, that we see a lot where doctors aren't signing notes, and or they just type in their initials. We've been seeing that with more frequency where, the absence of signed treatment notes is something that insurance companies, and rightfully so, frankly, are having a big issue with. But yeah, I mean, referring to the letter that you sent me the other day, I mean, it doesn't surprise me, frankly, and it doesn't surprise me because I have these conversations all the time that, providers are unaware that, you need to get your documentation completed, within 24 to 48 hours of that patient encounter. Otherwise, they will be more closely and harshly scrutinized by Delta Dental or you name the insurance company if selected for an audit. Because, I mean, how could you possibly in detail, appropriately document a patient encounter when you've seen 30, 40, 50 patients between that patient that you're now documenting and the date when you're doing it? It's simply not possible. And, I've had clients that have had dictation protocols or they have route slips, constantly trying to find a way to simplify and expedite the documentation protocols within the office. Whatever your system is, and I'm not here to say what system does or doesn't work. I think every practice has to figure out what works for them, but it has to be one where the encounters are documented and the charts are signed, again, within 48, no longer than 72 hours after the patient encounter.
Yeah, and that I do, I mean, I do a lot of expert witness
Yeah.
and affidavits and all that fun stuff. And I will never forget last year I was in Alabama doing some expert witness work, and I was in the courtroom. It was a big case. They paid me to be there for the 4 days that we were in court every day and the whole thing. And, you know, and I will never forget this for as long as I live. The one doctor was on the witness stand, and it had been 3 months. He did a chart note 3 months after the appointment. And the attorney who was cross-examining him, I guess is the right term,
Yeah.
um, said, okay, so it was 3 months later. So how could you be sure that you remembered every detail of that encounter 3 months later? And the doctor said, I have an incredibly good memory.
Yeah.
And the lawyer said, that's wonderful. So today is, I mean, I'll just use the date as an example. Today's November 11th. What did you have on August 14th for breakfast, and what time
Sure.
did you eat it?
Yep. Absolutely.
Uh, uh, um, well, I can't remember. I could remember you're under oath.
Right.
I will never forget that because that, like, you could visibly see the doctor go, like, move. I mean, you probably know that look, moving in the chair.
Yeah.
And I was just like, oh my gosh, that's like the coolest thing I've ever heard. And it was over cornflakes. This is this is awesome. I love that. I mean, it's easy for me. I have an English muffin with peanut butter every single day since I was like 26 years old.
There you go.
I know what I had for breakfast. Give me a date. I know what it was. But it's just the way it works. Now we have a question here. John said, "How does doc sign a note in EagleSoft? Unique login is not evidence of the doctor writing the note." Um, are the initials at the bottom, like in a lot of offices, the assistant is the one who signed into the software. They type out the note, they're using a template, which is a whole nother issue. Using an auto note, whatever it may be, are the doctor putting their initials at the end of the note? Is that sufficient, or what? When you're defending somebody, what are you looking for as far as that goes?
I want full name. I want full name, and ideally, I want there to be some sort of timestamp that identifies, the time that that note was signed. I don't want there to be any interpretation as to whose initials those are or what JS means. I want the full doctor's name and again the date in which that signature was entered or typed in, whatever the case may be, so that there can be no doubt that this was the doctor's signature. Point blank, period.
Okay. So like typing in at the bottom of that note that maybe is signed in under the hygienist username, but the doctor typing at the end of that note signed by, Dr. Rick Garofolo, whatever, 1:43 p.m. Boom. Like, is that
I mean,
enough?
I don't love the fact that they're signing notes that are when they're logged in under the hygienist username. I think that they should be signed in under their own username, frankly. But because especially when you're just typing in, your name, I mean, that could be done by anybody. And then if we find ourselves in a situation where we're trying to, you know, defend that this was in fact the doctor who signed it, I would love to be able to point to the fact that, well, no, they were signed in under the doctor's credentials, and it was the doctor is the only one that maintains his password for the EagleSoft software or whatever the software may be. We try to, layer on different pieces of evidence to support that, no, this was in fact the doctor that typed in their name. I'm not a proponent of having the doctor simply sign notes while they're signed in under a hygienist or assistant or somebody else's credentials within the system.
Okay. So save, I mean, and please correct me if I'm misspeaking here. I would say the hygienist saves the note. The doctor then goes in under their login, edits the note to include their
Yeah,
signature, and hit save.
absolutely.
Now it's resaved under the doctor's login. you know it was them. Theoretically, you know it was them who typed in their own name.
Sure.
What about for hygiene or recall appointments? Should there be a hygiene note and a doctor's note? Or can the hygienist put the doctor's findings of the exams in as long as it's separately signed then by the dentist?
Yeah, I think as long as it's separately signed, I mean, when it's separately signed, then that's the doctor's affirmation that the information is true and accurate. And so again, as provided there's that opportunity for the doctor to review and revise, I'm generally okay with that. Again, I'm always the biggest proponent of take the 90 seconds, type in the note yourself for something like a hygiene and just sign it yourself. But again, I recognize you're going from one patient to the next, to the next, to the next, and that may not always necessarily be realistic. So, the next least bad option is to have a hygienist, type that in. But again, the doctor's got to be the one that ultimately signs that and has the opportunity to review or revise that note before signing.
Okay. Perfect. Hopefully that answers the question. John, if you have any more, ask them. But now kind of the next thing, and there's a question here, which is great because the questions are kind of leading me into where I wanted to go anyway. This question is a Delta focus review the same as an audit? What are your thoughts or feelings on that? I mean, I always tell people you're on focus review. That's them telling you, we're giving you warning that we're going to be knocking on your
Yeah.
door.
Yeah.
That's not them ringing the doorbell. That's them texting you and saying, "Hey, we just wanted to let you know we're leaving our house now and we're on our way."
Yeah. It's audit adjacent.
Yeah.
So
Yeah.
no, I think technically it is not considered focus review. I would not consider to be an audit. I think it's easy to feel like they're not too dissimilar from each other because I think it's not uncommon for focused review to result in an audit or again I do think they work somewhat hand in hand with each other. But no, I mean I've had clients that are under focus review that have never been audited are under focus review for a while. They make some necessary or suggested changes to protocol, and eventually Delta takes them off of focus review. Others, that's not necessarily the case, and they're either on focus review for an extended period of time, and then that's accompanied by an audit. So it's really dependent upon the situation, but they're two distinct things.
Yeah. Yeah, no, they are. And I have seen that. And one thing I want everybody to understand, if you think the clinical notes and the narratives and the things you're submitting with the claims are only going to the claims processing unit and not to the reviewers, you are completely insane.
Yeah.
They're going to Delta, and anybody there is able to look at that information and see that. And I have seen offices that have called me and said, "I got a focus review letter. Oh my gosh." And they took it seriously and they changed the clinical notes. They added staging and grading for SRP. They made their documentation better. And we screenshot that clinical note and send it with every SRP that gets done. And 6 or 7 months later, we get the letter saying, "Hey, we're removing you from focus review," and it's over. But if you don't take it seriously and realize that it is, I'm going to use that now, I'm going to steal that and have to send you a nickel every time I say it. But, audit adjacent, that it is right there. It is, I have to come up with my own word, but I don't think I can find one better than that.
But you're right. I mean, it really is. It's almost like an extended release version of an education letter, and it's a bit more intrusive in that, they're going to be more hands-on than just sending you a letter, putting you on notice, and waiting to see what you do on your own. There's more engagement during that process, during focus review, where, and again, it's an opportunity. It's an opportunity to ensure that your record keeping and documentation practices for that particular procedure or procedures it is up to standard. Oftentimes, if you're being selected for focus review, they don't think that it is, and it's a time to improve on your deficiencies. And if you do that and you implement changes to protocol, you will find yourself out of focus review within a reasonable period of time. 6 months is generally true. And again, it's really just it's all how you view it. Yes, it's unquestionably a pain in the butt to be selected for audit, to receive an education letter, to be put under focus review, but it has to be viewed as an opportunity for growth. Otherwise, it's going to end up in larger ramifications, either in the short term or more likely in the long term.
Right. Now, just real quick, somebody had said we create two separate notes, one for hygiene, one for the doc. Each one signs their own notes. They have Dentrix. It's doable. I mean, that is, like you said, that is kind of the best case
Yeah,
scenario.
and whatever works for your practice, right? But as long as those are being documented and signed, great.
Right. Next question. Is it common for us to undergo focus review more than once?
Common? I don't think it's common, but I have certainly heard of it happening. Again, I think that means that, there's there's a need for review. Is it the same procedures? Is it the same codes? Is it something different? And how did focus review go the first time? And what's the span between the first and the second? I mean, there's a lot of questions that I don't think we necessarily should, get into here, but it's not uncommon. It's not totally common, and I think this is a warning sign, frankly, that more review is likely coming at some point. And so now is the time to make sure that record keeping, and I've said it 1,000 times, I'll probably say it 1,000 more times before we're done, but your record keeping and documentation protocols are up to standard, and if they're not, fix them.
Right, exactly. And one thing now, Devon interjected again, and this is something that we totally glanced over, and I can't believe both of us did. Typically, a complaint to the board or the insurance company is fuel for a subsequent lawsuit. All three things can occur from just one case stemming from one patient. I'm amazed at how many people don't realize the referrals that go on between insurance companies and boards and so on and so forth. And, I know Delta specifically, I mean, all of them really are very good at listing you did this in violation of Maryland Dental Board requirement, blah, 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 and here's the statute number and that silly little symbol, I forget what it's called, that's in all the statutes and
Yeah.
and they're very good at letting the board then know after the fact, hey, by the way, here this happened, or one insurance company tells another.
So there's something called the Healthcare Fraud Prevention Partnership, where there's roughly 300 different partners within this group, federal agencies, law enforcement agencies, private payors, every state's Medicaid program, where they have this agreement to share data and information. And so it is not uncommon for an audit to be the precursor to some greater regulatory enforcement investigation. In certain presentations I give, I sort of end with a few case examples where dentist or practice finds themselves under criminal investigation for conduct that they engaged in at the audit level of the matter, whether it be Delta Dental or United Concordia, whoever it may be, they're all very similar in this regard. If they see through their audit review, conduct that from their perspective rises to the level of criminal in nature, they will absolutely make a referral to the appropriate agency for additional investigation. And sometimes that communication and dialogue is already happening prior to the audit being commenced, and they're using the audit as an investigative tool in their toolkit to determine whether further and more obstructive investigation techniques are necessary, whether it be interviewing patients, God forbid, conducting a search warrant of the office. But audits are absolutely an investigative tool, not just of insurance companies, but of state and federal agencies as well.
Right. Can you say the name of that again?
Yeah, it's the Healthcare Fraud Prevention Partnership, HFPP. I think if you put that into Google, you should find, pretty quickly some additional information on there. But it's really, it's an agreement where they share data. There's access to enhanced data analytics. And again, it's all designed on eliminating or preventing fraud, waste, and abuse.
Right. Yeah. Devon says she already Googled it and now she needs another bourbon. She said coffee, but I know what she really wants. She really wants an old fashioned with extra cherry. We won't get into that. It's not 5 o'clock yet, Devon. But
5 o'clock somewhere, right?
I mean, technically, I guess it is. In Europe, it's 5 o'clock. So I have two things that I want to catch on because I do want to be respectful of everybody's time as well. But real quick, Amber asked if you're contracted with an insurance company, can you charge a lab fee? Here's what I'll tell you. A lot of people don't realize every plan, not insurance company, but plan, has a certificate of coverage that is a breakdown of the exact benefits for that plan. You need to see most insurance companies have a rule against upcharging lab fees for in-network providers. However, I have seen maybe 10 certificates of coverage. The Washington State Teachers Union, for example, allows a $348 lab fee charge for a full porcelain crown, over and above the allowance from the insurance company. But that's one plan. That doesn't mean you can do it for all Primera or all, Washington Dental Services plans. That one certificate of coverage. So you have to look, Amber, at the certificate of coverage to know. I actually just got mine from our agent for my employees' dental plan for next year, and I scrutinized the thing. For our plan for next year, and it specifically says in there you can't do that. So you have to get the certificate of coverage, and the next question is going to be, okay, how do I get those? Only the subscribers can get them. Unless it's a huge publicly trained like the metal workers, the car manufacturer employee, I forget what the union's called off the top of my head. All the guys that work at Ford on the lines and GM and all, their union certificate of coverage is public. You can Google it and find it. But my employees, or 95% of the companies out there, only the subscriber, my employee, can get that. The dentist can't call and request it. But in order to know if you can or not, you have to look at the certificate of coverage, and that will tell you. But like I said, I've seen maybe 10 over my 25 years that allow for that to happen. And is that a red flag kind of, Justin, to insurance companies that are looking, going, well, wait, you charged out a 2740, but then you added a $300 upcharge?
Yeah, absolutely. Anytime there's extra charges on there, that's a quick way to find yourself in insurance companies' crosshairs, unquestionably.
Yeah. And that was another thing in the letter from the insurance company that the mutual client got we were talking about. It said not all services were submitted. If you're charging the patient for something, you got to submit it. You got to send it on the claim form. And this office wasn't. They were, oh, well, we're doing a 4999 for laser, but we're not submitting it to insurance because the patient's paying for it. And then they get told, well, if you have them sign this HIPAA disclosure restriction high tech form, then you don't have to submit it. And you don't have to this, and you don't, and then you get audited, and they're like, oh, by the way, here's another spanking because you didn't do it. It just, you know, is out there. But yeah, not submitting things that you're charging for is another huge red flag. So now I have, you know, one more real question to address here, and then we'll kind of wrap up. And Amber, it's when you're in network, you've agreed not to charge extra. When you're out of network, I'll be very honest with you, I don't see a reason to charge an extra lab fee, because you can charge what you want for the service. You're not doing an adjustment, you're not doing a write. So if your D2790 full gold crown doesn't cover your lab fee, you're out of network. Raise your price for that service and then it'll cover it. There's no reason to add on all these extra 999 charges to 999, or worse yet. And for me, this is a pet peeve, Justin. I don't know about you. Admin made up in-house codes. We have, listen, people, I go to the code maintenance committee meeting. I sit in on there and they say if there's not a code for what you want, you use the 2999 or the 4999 or the 7999. That's an actual real live code. Not, we made up one in-house that is toothpaste. Well, there's a code for medications dispensed at the office for patients to use at home. Use that code. Don't use a made-up code.
But and I think just to that point, Rick, I think again we get back to training and education where look, there's a lot to know, and you constantly have to be looking for opportunities to strengthen and grow your knowledge in the space, and that's why your group and other educational groups and seminars are so important because there's just so much information out there that, one cannot possibly know everything. And
Right.
so just like it's important for providers to constantly be, availing themselves of educational opportunities, and they're required to complete a certain number of, continuing education units every registration period. Staff that's responsible for, billing and insurance practices at the practice should be looking for training opportunities as well. You've got to stay sharp. You've got to stay at the top of, the information that's out there, and constantly be looking for opportunities to grow your knowledge as it relates to dental insurance information.
Exactly. So that's that. It is, again, it goes back to continual learning. I mean, I'm sure a lot of people learned about the health.
I was like, the what now?
Thought I was having a stroke. Um, that group that
Yeah.
Cordovan Googling, it's, we have to continue learning. Now, with that said, and before I have one question that I hope you can answer. inside your wheelhouse, but somebody did ask, are there any soap or documentation courses that you would recommend? Feel free if you know of one to plug it. It's not my really, I mean, I do it, but it's not my favorite topic and it's not really my wheelhouse. I know Delane does some. Um, I mean, are there any that you recommend, or do you think you can put one together and do 3 hours at one of my upcoming classes?
I'm sure we could put in Delane. I don't think she's listening, but this message goes out to you. Delane is certainly my documentation go-to. I know she's well traveled and well spoken on the topic. I know there's lots out there. I'm sorry. I know there's lots of folks that are really at the top of their game in terms of documentation and how to improve your documentation practices. I don't have a list that I can recommend. But I'm sure that's something that we can work to address.
Yeah, we can fix that. And I know Delane does a lot of that. And
Yeah,
Roy Shelburne,
sure.
he is, I think right after our webinar, he's right after us as far as views on YouTube, the one I did with Roy.
Yeah.
Uh, they're two people that talk a lot on documentation. So that's a big thing. And just for everybody who's asking, because I just got hammered in the Q&A about information, I'll tag her in the post in the Facebook group when I post the YouTube link. I'll tag Delane in that as well as Devon, because we've talked about her a lot, and she can reply with her Venmo if anybody wants to send her money for um so just real quick, and I want to touch just on supervised neglect real quick, but we just got one more pop up, and then this is the last live question we're going to answer because Justin has things to do. um can you discuss the issue with auto notes and what is not acceptable? So that was the post that I took the snip of and put in the group, was the part of that Delta letter that said you're using cut and paste and every one of your notes is 98% similar. What is an acceptable amount of auto note or copy and paste versus what is patient specific?
Yeah, I think it's hard to say. I don't think it's like the percentage of crowns that someone asked earlier. It's really dependent. I certainly recognize that there's a place in the practice for note templates, but again, you have to make each patient note their own. So unquestionably, there's going to be overlap and similarities from one patient note to the next. But when you get too much into the copy and paste game of documentation, that's when you are prone to make easy mistakes where there's no chief complaint, or the chief complaint is inconsistent with the procedure being performed on a particular day. So again, I think it's ultimately figuring out what works best for your practice, but at the same time, it's a tool, it's not a crutch. And so you can't necessarily just go, well, all of this is these two patients came in for their regular 6-month cleaning. I can just go, well, same for this patient, same for that patient. You've got to change up, even if the message and the narrative is, conveying the same information, there should be some differences, either in, how it's said. It just can't be the same one after another after another. Now, one or two, that's okay, that's going to happen. But it's every single note for every single patient where it's just looks like insurance companies think it is just the same note that you're just constantly regurgitating from one patient to the next.
And that's what it is. Because listen, I teach the same class. I do the same class seminar 10 times over the course of a year. But every one is a little different
Yeah.
because I'm not speaking from a script, I'm speaking.
Sure.
And you get into trouble when you are using the script. Because if somebody came to see me live one time, well, why come again? It's the same exact thing. It's
Right.
the same with your clinical notes. They're going to be different. And yeah, you may say that same patient presents for a prophy exam and 4 bite wings 37 times a day, but it's going to be day over day. There's going to be a little difference. There's going to be, you're going to say something in a different order than you did
Right.
yesterday every now and then, and that's how you know. And then you're running into an issue where this, mutual client was copying and pasting and billing out for comprehensive evals, but the clinical note said patient presents for limited or patient presents for a DO 120 when you build out a DO 150. And that's where you get into documentation issues because now it's a question of you didn't bill for what you said you did. And billing for something you didn't do typically isn't an acceptable thing to do.
No, that's when you're going to find yourself in hot water, as we like to say.
Right, exactly. So, all right, last thing, and then we'll wrap up because I know people have lives and offices to get back to. And Devon has to go get an old fashioned at the steakhouse. Um, and again, this may not be perfectly within your area of concentration, but it's something
Sure.
that comes up so often. Supervised neglect.
Mhm.
If a patient, you tell a patient you have periodontal disease, all your teeth are going to fall out of your head, you have bacteria eating your jawbone, and it's going to go into your brain and kill you. And they say, but all I want is a prophy. Is it supervised neglect to do the prophy?
What does the documentation say?
The documentation said they have periodontal disease, and you've told them they have periodontal disease, and they're refusing treatment and just want the cleaning my insurance will pay for.
I personally don't think it is, provided that, all of that is extensively documented and it can't just be on one particular patient encounter. It's got to be every time that they come in, it's a consistent refusal. You need to document that you've explained to the patient what is happening, why, what the patient could do to, control or improve the issue, or what treatment could help improve the issue. And if they're consistently refusing that, that has to be documented. I would have them sign the treatment plan that they're refusing to do it. I would incorporate that into the patient record. And if they're only interested in the prophy, I don't think that that is supervised neglect to perform the prophy, provided that, the documentation regarding the patient refusal and all the risks and benefits of have been clearly articulated to the patient. Again, not just one time, but every single time. And so when I think you start talking about a situation where that is what is being expected of the doctor, is that really a patient that you want to have long term, where you're constantly doing what is necessary from a CYA perspective? You have the opportunity to terminate a patient. And if the patient's not going to follow your clinical expertise and agree with your clinical decision making as to what is in their best oral health, um, then why is that a patient that you want to continue to treat on the go forward? Especially, just for purposes of use of the same example, when we're talking about the reimbursement of a prophy. The headaches just aren't worth it. And so in a situation like that, I would say you, again, detail extensively the conversation and the exchange between the patient, you perform the prophy, and then you really consider whether that's a patient that you want to continue to be at your practice.
So there we go. So there's the answer. It's not supervised neglect, but it's not a patient that we want either.
Yeah.
Provided you have all the documentation. I appreciated the lawyeriness of your answer there. Um, that definitely works. And I agree with that. I wouldn't want that patient if you don't trust my medical decision making with this, you're not going to trust it when I say you need a crown. You're not going to trust it with this. And who really wants that patient that only wants what insurance is going to pay for when we all know insurance doesn't pay for 90% of the things the patients actually need anyway?
Well,
So,
and that's the patient that you may ultimately get them to agree to go down your recommended course of treatment, but you know that they're going to be a problematic patient either because they're experiencing pain or discomfort after the procedure. It doesn't turn out exactly as they expect it to, and then you're putting your malpractice carrier on notice because you have a patient that's threatening to sue you. Again, I think just avoid those headaches at the outset and just if they're not willing to follow your expertise, then let them go somewhere else.
right. Yeah, fine. I, I say the same thing to patients that I say to employees who aren't happy. I'm going to give you the opportunity to go be happy somewhere else because this isn't the spot. So, well, Justin, I appreciate you taking the time. I'm sorry I sucked an extra 16 minutes of your life away here at the end. Um, but I certainly appreciate you taking the time. I'm going to make sure everybody that I put Justin's contact information in the uh the about section of the YouTube video as well. I'll also tag him along with Delane and Devon when I post the replay in the group and send out the email. So, feel free to reach out to Justin if you do need help. I do all the time, usually on Friday nights when he's supposed to be at home with his family, and a client calls me and I say, you know what? Let me send you right over to Justin because I don't want to deal with you and I'll let him. And, uh, I'll put all his contact info there. If you need anything, feel free to reach out to him. Justin, thank you again. Appreciate you taking the time. Um, you know, and I will again post this all on YouTube. Contact info will be there. Thank you, everybody, for attending. Thank you for those of you who hung out to the very end. I definitely appreciate you. I'll also put my contact info there. So if you have any questions you're scared to talk to a lawyer about, message me. I'll definitely
Thanks
be
everybody
there.
for putting up with my coughing and drink breaks. I'm still getting over the health stuff that prevented us from recording this last week. So thank you again, Rick. Appreciate the opportunity to have the chat.
Absolutely. Thank you. And thank you again, everybody. Everybody have a fantastic rest of your day.